So just tell us, I guess, a little bit about who you are, what you do, just so everybody who doesn't know are
Yeah,
armed.
so absolutely. So my name is Helen. I'm a dual board certified nurse practitioner with my doctorate in adult gerontology medicine and family practice, and I'm menopause certified. So that's probably the most relevant piece of information. I treat primarily perimenopause, menopause ladies, but also other hormonal disorders like PCOS or POI, PMDD. Um, recognizing endometriosis and treating that appropriately. And I'm licensed for California at this point. So I don't know if I'll expand into other states. California is so huge and the need is so vast. So I haven't found the need to expand yet. But yeah,
Yeah. And
go ahead.
you're all virtual, right? So everybody anywhere in the state of California can see you.
Yeah, yeah, primarily virtual. I'm hoping to open a little office here in San Diego just so people who are local can have that option if they want to come in and see me face to face. So.
Okay, awesome. So tell us a little bit more about the hormones and kind of, I know especially in pelvic health, that's something that is kind of a big buzz. And then I know a lot of patients who go and they get their hormones done and they say everything's normal. And then that's kind of the
Oh,
end of the
yeah.
discussions.
That's one of my huge bugaboos, to be honest. We'll start right away with a rant, right? No, I love that you asked that because this hopefully will really help get your listeners, our listeners, the care they need. So I don't want to make like huge blanket statements, but it's going to sound like that. And I'll put some caveats in there. But labs are not very helpful during perimenopause. And the reason, so hormone labs. And the reason for that is because our hormones are going crazy during perimenopause. So you might get them drawn on Tuesday morning. They look perfect. Your doctor doesn't know what else to say, but your labs look normal. But by Wednesday night, they're completely different. And the same thing can happen in the space of a day. And this is why we're having wild symptoms, wild mood fluctuations, why we can't sleep. And so really best practice during perimenopause, especially, but even menopause, I don't necessarily need to see your lab levels to know that you're in menopause, is best practice is to treat you based off of your symptoms. And so many women are just getting dismissed right and left all the time, every day by a healthcare provider and system that doesn't know what else to do but say your labs are normal. And so this is my big bugaboo. And I do teach women how to advocate for yourself at the doctor's office, what to say, what to ask for. But, I don't want to say labs aren't useful because we do need to rule out things like vitamin deficiencies or thyroid could be way off and that could be mimicking other hormonal imbalances too. So,
Yeah. So say somebody kind of went through that whole spiel. I know I've been on that on a personal note. For as
mhm.
long as I can remember, had periods that were very spaced out and, maybe every 20 days, but maybe every 40 days. And there was just kind of no rhyme or reason, heavy bleeding and all that kind of stuff. Had hormones done and, oh, well, they're all normal and there must be nothing wrong with you. And,
Yeah.
we can give you some birth control. And that was kind of the only option from several providers. I finally found an endocrinologist who kind of said like, oh, well, even though they're in the normal range, they're not really, relative to each other where we would expect. And so say somebody kind of went through something similar to that, if they saw you, what would that kind of look like in terms of taking it to the next level?
Yeah, absolutely. So I actually have my patients fill out an obnoxiously long intake form, and it's just so important. I want to know your symptoms. I want to know your past medical history. We need to see any red flags. We need to know your period history because things can be hiding. I mean, you're, a pelvic floor therapist,
Yeah.
that things can be hiding and undiagnosed for years, like endometriosis or, different venous conditions or whatever, and vulvodynia and stuff. So I do need to know that, but what I would do is I really have you prioritize your symptoms. We go through everything together, that intake form I review beforehand, so I'm putting the puzzle pieces together. So we do that together as well.
Okay.
And then what I do is I do something called hormone stacking. If you're a candidate for hormones, let's say you're having crazy mood swings, irritability, rage, right? You hate everybody at some point in the day. You can't sleep. You're consistently waking up at 2 or 3 in the morning. Your joints are hurting. You've got some cyclical headaches. What are some of the other most common low libido, vaginal dryness. So we kind of prioritize these, and I do something called hormone stacking. You never want to stack, or you never want to like just start a bunch of hormones at once, because then if somebody has side effects, or we want to know what's working, what's not working, so then we don't have to start at ground zero. So I would prioritize your symptoms based, and say, or you've already prioritized them for me. So let's say you're mostly having mood issues and trouble sleeping. I might prioritize progesterone first. I'm going to be like, okay, let's start progesterone. Let's see how you do for 2 or 3 weeks. I'll still give you a prescription for estradiol, but let's give the progesterone a chance to work. Let's see how you do on it. And then let's trial the estradiol maybe to hit those joint pain, and your night sweats. And so it's actually a really amazing way of treating someone's symptoms. Birth control has its place during perimenopause, but primarily I would not usually use it except for in circumstances as an additive treatment for maybe super heavy bleeding. So maybe, because the micronized progesterone that we tend to give isn't always going to have an impact on bleeding. And I don't want you just bleeding, right? Because then we get anemic and it's a pain in the butt. Anyway, there's also other things like IUDs and things we can consider. But birth control in and of itself is not really going to have an impact on mood symptoms, sleeping. But many other doctors that's all they know how to do. And so they're trying, but
Yes, I found especially in women's health, both for myself, but I think also all of the patients that we've worked with, there's a lot of providers who I don't think they mean to do harm, but they do harm because they're kind of speaking outside of what they actually know,
yeah.
because you don't get taught this in school, unfortunately.
Yeah, and our goal really is to get all specialties, all primary care providers very comfortable with at least just starting hormones. Does that need to be your specialty? No, but you should know by now the basic starting doses for women and your basic options. Like, it's not hard. It's optimal that you're really good at it, but we don't expect every provider to be really good at it, but at least get to a starting place. And then, if you need to send them to somebody who can kind of tweak the dosages, great. But that's our perfect world that we dream about.
Right. Kind of along that, if you could have one thing that every like perimenopausal or menopausal, postmenopausal woman knew, what would that one little clinical pearl be?
Yes, that what is common is not normal. And I think that that's kind of my mantra, because as well as letting them also know that you're not broken, right? If you're having these rage and anxiety and sleep and, weight changes, you can't lose, weight gain, you're not broken. These are a lot to do with hormonal fluctuations. But yes, common does not mean normal. So you're having urinary leaking. And I'm sure
we say the same thing in pelvic health.
Yes.
Common to have leakage, but that doesn't make it normal.
Yes. It doesn't matter how many babies you've had or how old you are or how many aunties that have told you like, oh, well, this is your life from now.
Sweetie.
Yes. It's not, it's not normal. And 30-pound weight gain over a year, that's not normal. Is it common? I get a lot of women with that. Yes. But there's a lot of reasons. So we really have to uncover root causes. And but that's probably what I would really, really like women to know.
Okay. Along those lines too, we get a lot of people who.
Oh, I just lost your sound. Sorry.
Oh,
Sorry.
Can you hear me now?
Yeah, but I lost the whole question. Sorry.
That's okay. So kind of along those lines, we get a lot of women who get told that, it's normal for sex to hurt, or they're not really given good options in terms of like, oh, we'll just use lube. I actually had a friend recently who went postpartum to her OB, said, I'm having pain with intercourse. And they said, here's some lube and we'll do a pelvic ultrasound to see if we can find anything.
It makes the worst is like, here, have a glass of wine, right? Before sex.
Just relax. You'll be fine.
Yeah. It's unbelievable, really, because if we had a man come to us, right, most providers, and they're like, oh, like my penis really hurts during sex, we would never. Yes, we would never dismiss it, but somehow it's okay. For women, and it's not okay. Like, it's horrendous how women, especially in the sexual health world, and I'm sure you hear it even more than I do, but it makes me crazy, as you can tell. Like it makes me enraged and so sad at the same time. But yeah, so sex should never be painful unless you want it to be, right?
Yeah, that's the
Right?
difference.
If that's your thing, that is a total different thing that we don't need to talk about today. That's great. But if sex
Should be able
is,
to control that too.
yes, yes. But if you're having painful sex and that's not what you're after, that is not normal. And what happens is that is generally only going to get worse with time because your body starts developing these involuntary responses. And Emily, you can talk so much better than I can even in that, but the musculoskeletal responses, the nerve pathways, right? We develop these guarding mechanisms out of protection. But there are some really, really good and often very easy, and again, at the risk of overgeneralization, very easy fixes to sexual pain, especially if it's just hormonally mediated. I have had women 5-10 years out that haven't been able to have pain-free sex. In fact, have just stopped even trying. And I'll put them on a localized hormone cream. Usually I'm really going for the combination estrogen and a little bit of testosterone cream. And I'm not kidding you, within 6 weeks, 2 months, they are having pain-free sex and they are enjoying themselves and they are happy. Some of my older women are really shy about it. And I'm like, no, like you just made my day. Like I love it. And it's really one of my favorite things to treat because the joy and also sometimes just, it's such a simple fix. And again, it's not always. Sometimes there's, as you know, very muscular components to this. Sometimes there's neuroproliferative things, which can be a little more complicated, but often I see this with women who maybe have been on birth control for decades and their testosterone is just bottomed out because of that. And, but there's other reasons, of course, as well. Prolonged lactation. I breastfed for 3 years. I was dry as a bone down there, so I've had to do my own treatment. But yeah, I'm a huge, huge fan of pelvic floor therapy too. I honestly think every woman should go at least once for an evaluation. And then, yeah, I'm sure you
And we
agree.
see on the pelvic floor world a really big, I guess, overlap between hormone health and when we're having pain
Yes.
with
Yes.
intercourse. Some of our patients, we can do all the muscle work and everything else around it, but if we don't address the hormones, we're always kind of chasing what's going on. Maybe my muscles are tightening up at least partly because I've got a lot of dryness and that hurts because
Yes.
there's friction and, what can we do to
Yeah.
address that? And so we see a really good really good outcomes when we're combining kind of pelvic floor therapy with services like yours where we're addressing
It's,
that hormone health.
yes, it's amazing. It's almost like this magic combination, right? I would, almost go out on a limb and say that because it was interesting. I went to the International Society for the Study of Women's Sexual Health conference a few weeks ago. And the first lecture of the entire week was part of it was on how many androgen receptors they've discovered in the vulva and the vagina. And so when you are deficient, yes, it is incredible. And it was such an amazing lecture. And I finally really understood why this cream that's even better than just the estrogen cream works so much faster and more efficaciously because it's got those testosterone and we're just making those receptors so happy and doing their job so well. So yeah, it's really exciting treatment. So
Yeah. And we have some patients, I think hormones have kind of gotten a bad rap on social media. I know they just took out the FDA warning on the estrogen prescriptions, the warning that this is going to kill you, you're going to get cancer, don't take this if you're breastfeeding and blah, blah, blah. And so I know they've kind of taken some of that stuff down. But how do you address or what do you have to say to people who are very hesitant about hormones just because of kind of the buzz and the bad rap they've gotten?
Yeah, amazing question. And I do try to address this at all of my live events and everything. And yes, so the short answer is that hormones don't cause breast cancer. There's a really long answer that involves where this information all came from. It was from data that was disseminated prematurely to the public and really not presented well. It's not what the data shows when we really parse down the information. What hormones can do is, if you already have breast cancer, and it's hormone positive, right? We're not going to give you progesterone or estrogen if it's, estrogen, progesterone positive, because we don't want to necessarily, we don't want to proliferate those cells. But it's much, much more nuanced. So hormones actually, the study really actually shows that hormone therapy, especially estradiol alone, actually decreases breast cancer risk pretty significantly. And it's really, really exciting. And we're actually, we don't have enough data, and I feel like we're never going to have enough data in our generation, at least, on women's health.
But we're not there, unfortunately.
No, and they don't, it's very expensive to run these studies. But actually, we're seeing some incredibly exciting data on the breast protective effects of testosterone therapy. Like normal physiological doses of testosterone for females, not the testosterone pellets or anything, but just giving you back what your body needs. So there are some pretty exciting things in the hormone world. So for those of you who are unsure or still, or have heard, right, through no fault of your own, that hormone therapy is unsafe, every time we administer hormone therapy to a woman, we are ruling out risk factors. There are red flags. There are some hard contraindications to hormone therapy, but honestly, it is far less than you think. It is maybe 3 or 4 things. There are some yellow flags, which means that is very individualized care, and we do a lot of shared decision making. And then there's, of course, the people who are absolute green lights. But this is why a good hormone provider, like me, will have this obnoxiously long intake form, is because I need to make sure that this is appropriate therapy for you individually. So I know that was a long answer. Sorry.
No, that's okay. And I think a lot of people don't realize how much our hormones do. And I think that's probably partly why you have such a long intake questionnaire and you're asking about every function of our body, is because our hormones basically impact every function of our body. From sleeping to digestion to mood to, you name it, our hormones impact it.
Oh, one of my favorite subjects in the whole world. Like, women often come to me with itchy ears, and they're just delighted when I tell them, well, this is because you have estrogen receptors in your ears. We can take care of that. We can put a little Q-tip with estrogen cream on, right? Dry skin, hair loss. I'm passionate about protecting women's bones and hearts. And hormones are not just about symptoms. So some ladies come to me and they're like, oh, I'm way past that. I sailed through perimenopause. I'm like, great. You were one of the lucky ones. But let's now talk about the bone loss you're invariably having, the cardiovascular risk that you're invariably having, because estrogen is highly protective of our heart, our bones. Hormones are very protective of our brain. So the brain fog is because we are just packed full of estrogen, progesterone, testosterone receptors in our brain. So it really impacts exactly what you're saying, every single body system. That weight gain that you're having, that belly fat, we gain almost twice as much visceral fat during our like menopause transitional years. So, you see that elevated cholesterol, and you never had high cholesterol, right? Your body is trying to pump out more estrogen through that cholesterol. And also just the metabolic shift. So yeah, nice if you don't have symptoms anymore, but think about your bones, think about your heart, think about your brain and your skin and your hair. Yeah.
Yeah, that's something that we kind of preach, especially the bone and muscle impacts in physical therapy, because as we get older, we do just tend to get more sedentary. They actually came out with a study, was it ACSM, about the recommended guidelines for exercise, and that only 23% of women are meeting the strength training recommendations. And strength training is really important for strength, so that we can do things like get on and off the toilet and get on and off the floor, and those simple things.
Yes.
But even, our risk of osteoporosis and things. I can't tell you how many clients have had a DEXA scan while they're, seeing us for pelvic floor therapy, and they're shocked that they have osteoporosis. And it's like, well, when was the last time you loaded your joint with strength training or exercise, things like that? And they haven't. I think we
could have a whole we could have a whole session on this, and we probably should in the future if your followers would like it, because I cannot talk enough about this and emphasize it. Like 50%, Emily, of untreated menopausal women, 50% of us are going to have an osteoporotic fracture in our life. Why are we not talking about this more, right? Why are we not, like, it's ridiculous that the guidelines here in America are no DEXA scan before 65. That's
Oh, I didn't
insane
know
to
that.
me. Yes, like insurance doesn't want to pay for it. Like I have to jump through hoops to get insurance to pay for it. I mean, I will document up the kazoo, like, oh, family history of osteoporosis. Oh, we have a little bit of like height loss or back pain, like anything I can do to get it covered, because 65 is way too late. And
Yeah.
and what's even more stunning, these statistics are 20 to 30% of women who have a hip fracture from osteoporosis will never come home. This needs to be talked about a lot more, right? Like you cannot come home. Either you have to go to, assisted living, or honestly, to say it bluntly, is they die.
Yeah.
And so this is huge. Like, I don't want to be one of those women that dies from an osteoporotic fracture. Like, give me those whites and give me, eat your protein. You need to be eating 100 grams of protein minimum a day. And this is not a fad. This is not like just something passing. This is actual science. Maintain those muscles to maintain your bones.
Yeah.
Yeah,
I think we do need to do another talk about that, because we
I
could talk
do.
about that for a while. I will
Yeah.
mention too, we see a lot of people who, like in the hospital, get UTIs. They get confused. They fall because they're confused from their UTI, and then they break a hip or something. And there's a lot of issues with that. But I know something like a vaginal estrogen kind of decreases our risk for a UTI, right?
Yes. In fact, I have my little bag here. Just happen to have it on my desk because I use it for my patient visits. But this little tube is $13 at Cost Plus Pharmacy. You should never be spending hundreds of dollars on it. This can literally save your life, or save your grandma's life, save your mom's life. Every woman basically in the world that is perimenopausal and above should be on some form of vaginal vulvar hormone cream the rest of their life. This is the compounded version that I do, just because it's got that little bit of testosterone in, a little more higher concentration of estradiol. But if you can't get anything else, get this. And literally we're talking, if every woman was on this, we would be saving the healthcare system billions of dollars. And it's no exaggeration. The studies have been done and the numbers, crunched out. But yes, that can be super, super helpful for UTI prevention.
Yeah, I love Dr. Rachel Rubin, all her stuff
Yes.
on that. Like, why are we not giving every old lady in the ER that comes in with a UTI a prescription for vaginal estrogen?
It's true. When I was in geriatrics, I would prescribe it to women, and you could see the UTI rates drop. Like, it's profound. Even older women, you're never too late to start that. So
yeah. Now I know you have the midlife membership. Let's kind of close up with that. Tell everybody what that is.
oh, I'm impressed that you know that. I just soft launched that this month. So yeah, so super, super excited about that. So I actually started my practice with standalone visits. And I just want to take a minute to explain that, because this is very important as to why I'm doing the membership. Is standalone visits are just not adequate, I've realized, for treating the complications that is perimenopause, menopause. Like I said, many women come to me, I want you to help me lose weight. I want you to protect my bones. And I really need hormone therapy. And I'm having like vestibulodynia. And
Sounds like pelvic floor therapy.
Yeah, I can't sleep. And I'm like, okay. And my visits were going overtime, and I'm struggling, to get people back, and they're having to pay for follow-up visits. And I'm like, we got to switch over. So I actually started, a concierge membership, very excited about it. We start with an initial consultation. It's a 75-minute visit. I actually did like a 90-minute visit yesterday. We do a really deep dive, like I said, into everything, your priorities, your goals, your past medical history. And then I create a proposed plan of care, very detailed after visit summary. And at that point, you're invited, you're welcome to join the midlife membership, which is like an intense, hand-holding, comprehensive 4-month foundation phase, where you have visits as needed. We dive into labs. I'll send referrals to pelvic floor therapists, or recommend, different nutritionists, dietitians, psychotherapy as needed, which obviously any of that is up to you, whether you want to do. And
I'll
then
just say I find collaborative care is the best. So for anybody hesitant about seeing multiple providers, you're going to get to where you want to
yes,
be better than operating on your
yes.
own.
And you're not necessarily going to need all of us all the time. Like this
Yes.
is the starting out phase is really laying the foundation for the rest of your life. You could be living another 40, 50 years, and all of our goals, Emily's, mine, that, is to not just increase lifespan, but to increase health span and functional longevity is probably, I like that term much better than just longevity. But then after the 4 months, if you're relatively stable, and we can prolong it if we need to, but then you can just stay on as a maintenance membership for a small, like monthly fee. And that allows me to continue to just take care of you as things arise. You don't have to like start all over with a provider. We do an annual every year, and, medication renewals. Yeah. And it just is working so well. I'm just so excited already by the patients, signing up for it and just the ability to care for everyone better. So,
Yeah, that is exciting. Now, is that all on your website? So if somebody was interested, they could just book through your
yeah.
website? Okay.
So, yes and no, it's coming.
Okay.
My web designer is just, we're tweaking the last few things. She's kind of waiting on me. I've been so busy.
I
And
understand.
Yep. In fact, I'm even supposed to like take a picture for her today. I've got my little tripod set up. Yes, but anyone can book a free discovery call with me. It's no pressure. You can talk about your symptoms, ask me any questions. You can book a 15 or a 30-minute one. Absolutely happy to talk to anybody about anything, and answer questions. So,
Awesome. Well,
yeah.
thank you for joining us today because I know that's something that our clients are always wanting more information about is hormones.
Yeah.
If
I
it's
would
okay,
love. Oh, sorry. I was just going to ask you to say a little bit about yourself and your practice because I would love to also post this and my followers need to know who you are.
yeah, so I'm Dr. Emily. I'm a pelvic floor physical therapist. We have two clinics in Southern California. One is in Rancho Cucamonga and one is in Apple Valley. We do accept most insurances, so that's definitely a,
Amazing.
a bonus because I know, women's health can get expensive. But we treat kind of anything and anything, everything and anything that has to do with, from your knees to your shoulders and anything in between. So whether that be urinary incontinence, whether that be you're pregnant, that can be bowel issues. So either leakage of gas or poop that you can't control. That can also be chronic constipation. A lot of the things that we talked about, pelvic pain, pain with intercourse, you name it, we can typically help with that.
Amazing. Amazing. You guys are some of my favorite people on the planet. Seriously. Pelvic floor therapists. I'm like, send all my patients to you guys.
And I will just throw in the sooner you come in for your symptoms, typically the easier it is and the less amount of time it takes for us to resolve them. So if you've been having issues for like a month and you come in, we might only need like 3 or 4 visits and get you on your way. And now things are back to normal and you can kind of prevent it. Versus the people who come in and it's been, years and years. I've been having pain since my last kid and now they're 18 and they're going to college. Those are just, that doesn't mean we can't do anything. It's just going to take us a little bit longer, which then means more money out of your pocket and things like that than if we address it now. Think about it almost as like preventative care or early intervention versus waiting until now we have this huge issue.
Yeah, absolutely. 100%. I love that.
Um, but are you okay? I would love to post like a little question box so that if anybody has questions after they watch this, we could answer them.
Yeah. I
Okay,
love that. I've never done that. So you might have to tell me how or what to
that's
look for.
okay.
But yeah. Yeah.
Um, but yeah,
This
and then
was
I would,
so much fun. I think I want to do more Instagram lives. I think it's so cool.
yeah, I would love, we'll have to talk and see about scheduling something so we can talk about osteoporosis and musculoskeletal health in terms of hormones too, just
Perfect.
'cause there's not enough time for that either.
I know. I know. It's so true. Yep.
Um,
Perfect. Okay. Well, this was really fun. Thank you. And thanks for coming like so prepared with amazing questions. I
oh,
loved it.
yes, of course.
Yeah.
But yeah, so this is Helen Stearns for anybody that just logged on a little bit late. She is a DNP and deals a lot with hormone health, women's health, um, kind of across the lifespan, but really perimenopause, menopause. Correct me if I'm wrong, are kind of
Yeah.
your
Yeah.
What excites you?
Yeah. Sounds perfect. Yeah. Perimenopause is my jam, but honestly, I love it all. So
But if you have any questions about her services at all, you can go ahead and check out her website. There's lots of information on there. I was just looking on there today. But otherwise, thank you very much. And I hope you all have a great day. Helen, I hope you have a great rest of your day, and we will be in touch soon.
you too. Thanks, Emily, so
Yes.
much. All
Thank
right. I'll
you.
talk to you soon. Bye bye.
Bye.